Hello! Today we are doing our live clinical Q&A with expert answers on allergy and sensitivity testing for Infinite Allergy Labs. Today we have our experts, Kris. She's our clinical consultant and registered dietitian at Infinite Allergy Labs. She has 24 years of experience and she has built a distinguished career in nutrition and wellness. And at Infinite Allergy Labs, she provides clinical guidance to doctors and patients and helps them to interpret and apply food sensitivity results to improve the patient outcomes through evidence-based nutritional care. And we also have Dr. Jennifer Knaack. She's our laboratory director and clinical consultant, and she's a biomedical scientist and clinical laboratory director with over 15 years of experience in clinical diagnostics and assay development. She has led multiple CLIA certified laboratories and guided providers nationwide in interpreting complex test results. At Infinite Allergy Labs, she ensures that every result is accurate and meaningful and helps our clinics deliver personalized evidence-based care. So today we're going to go through the introduction to our lab. We're going to look at our laboratory. We're going to discuss the immune markers we assess, and we're going to have a discussion. So our laboratory at a glance. It was founded by our CEO, Nick Juma, to help patients find the root cause of their symptoms and diseases. After years of research, we led to the creation of the FAST test with a bunch of scientists that he got together, and we established our lab in 2017. We've already expanded into new spaces. We just opened our new space in Dallas. We have a network of 2,500 plus healthcare providers, and we've performed over 35,000 tests. Now I'm going to hand it over to Dr. Jen and Kris to discuss the immune markers we assess.
Thank you so much, Aoife. Thank you guys all for coming and joining us today. We're really excited to have another one of these webinars. This is my first one with Infinite, so I'm really happy to be here with Aoife and Kris and to have you guys along with us. We're hoping today to address some of the common questions that we are getting at the lab. And at the same time, we want to just give some general background information on the markers that we are assessing, what you do with this information, how you interpret tests, and hopefully give you a better handle on what to do with the information we give you and how to apply these tests to patient care. So I want to talk about the immune markers that we're looking at in the tests. Everybody is very familiar with IgG. These are the classic immunoglobulins that most allergy tests out there are looking at. They're associated with sensitivity reactions. So when we talk about food, we're talking about like a delayed reaction. You eat food at 24 to 72 hours later, you start feeling bad. You got diarrhea, bloating, brain fog is pretty common, headaches. It's very difficult to associate the food that you've had 24 or 72 hours ago with these symptoms. Sometimes people are really good at catching on to what caused the symptoms and being able to eliminate those specific foods. Sometimes it's not as simple. Along that pathway, we also have complement system. This is basically the booster of the IgG pathway that leads to inflammation. Having the complement system activated can really boost inflammation like 10,000-fold. So this reaction works alongside IgG, but also with IgM and IgA. And the reactions actually can happen pretty fast, on the order of minutes to hours. But the inflammation itself isn't going to be noticeable until you get, to a critical mass where you start seeing that inflammation. So that is basically what we think of when we think of food sensitivity. We're thinking of the inflammation and we're thinking of that sensitivity that comes later in time. When people say allergy, they're generally thinking of hives and sneezing. We think a lot of about anaphylaxis. Peanut allergies have been very, very common in the past decade. And these are mediated by IgE. These are immediate reactions. They're going to happen within 2 hours. It's very easy to associate what you've eaten with what's causing these symptoms. So there's this other side of this immediate reaction, and this is IgG4. This is a different immunoglobulin. It's sort of a strange IgG. It's a little unlike the other IgGs that are out there. It works against IgE. It actually mediates and tempers down the effects of IgE. It does this in a few ways. It will bind directly to antigens themselves, so it will compete with IgE. But it also binds to receptors that have inhibitory pathways for B cells and other immune cells in the system. IgG4 takes a long time to build up. It can take weeks or months. So IgG4 is something that will build after you've had chronic exposure to a specific allergen. So you're going to not notice that that's around until it's been a while. You actually see IgG4 and that tolerance in beekeepers. Also, I'm a laboratorian. We see this a lot in our laboratorians who work with mice and rats. They tend to have these IgG4 antibodies built up because they're constantly exposed to the allergens that mice and rats have. And that's the same with beekeepers. They get stung a number of times and they start building tolerance against the venoms from those stings. So those are the four major biomarkers that we're looking at. And that's what they're doing in our system. That's we should always associate IgG and C3b and D with that sensitivity and inflammation reaction. Those are slow. And then IgE and IgG4 are associated with that rapid allergic reaction and then the tolerance of that reaction. I couldn't have this conversation without talking about food intolerance. This is really important because there's a lot of confusion between sensitivity and intolerance. IgG moderates food sensitivity. This is an immune reaction. Food intolerance is something different. This is actually the inability to digest or absorb certain foods. This is something along the lines of lactose intolerance. This is very common. Some of you know about sulfite intolerance. I love dried fruit, but I can't have it too frequently because the sulfites in there cause me to have problems breathing. I start having like wheezing. So that's another intolerance. The onset for these reactions are pretty fast, 30 minutes to about 2 hours. Again, this is pretty easy to associate the food with the symptoms that you're having. But what's happening here is different. So in the case of lactose intolerance, you have a person who's missing the lactose enzyme. They're unable to digest lactose. That causes other upset in the GI tract, among other things, leading to lethargy, migraine. We see the bloating, gas, and so on. We have ways of treating some of these intolerances. Lactate is a really great option out there. You take the lactose enzyme that you're missing, and for some people, they're able to have lactose again, at least for that meal. We do have supplements out there for even supplementing digestive enzymes as a whole. But I want to make it clear that intolerance is not what we're talking about here. So sometimes you will hear patients say, "Hey, I know when I eat this food, I have a problem." But what they might be dealing with is an intolerance to that food, not necessarily a sensitivity. And you may not see those sensitivities, the IgGs show up on your test results because you're not dealing with an immune reaction. So when we sent out this notification that we wanted to hold this seminar, we wanted to know what questions you had. So we said, please leave us your questions because we have answers. And we got a lot of questions. We also wanted to throw in some of the questions that we get on the regular. And Kris and I did our very best to try to group these together. So we're going to talk about interpreting test accuracy and immune markers. We'll talk about testing in clinical practice and how we use these tests. And then we're going to talk a little bit about food patterns and relationships. So the rest of this talk is primarily going to be more of a discussion between me and Kris. And certainly if you have more questions, feel free to drop them in the chat box. Aoife is going to be moderating for us. And if we have time, we'll get to those questions and answer them for you. And if we can see them and fit them in while we're talking, we'll address them while we're talking. All right. Kris, are you ready?
I am. Can you see
Okay.
me? Am I on?
Yes,
Okay, you can
you're
hear me
there.
okay? Okay.
Kris, she does a lot of our consultations. She is our in-house guru on consulting patients and helping the providers with giving patients the care that they need and interpreting our results. So Kris is my go-to for, what do I tell a provider who's asking a question that I've not seen before? So, Kris, we're going to
I
talk
can,
first about interpreting test accuracy and immune markers. So it's a little bit of a broad topic. But one of the first things that always gets brought up is that there's conflicting information about IgG research. Um, Particularly, do you ever get questioned about the lack of research supporting IgG testing? And this is so common. What do you think about that?
so this has been a question I get often since I've started working at Infinite. I think back in the day, IgG wasn't studied as much and not used as much, and so there wasn't a lot of studies about IgG, and also not the other pathways that we're looking at as well. So now we do have some more research on IgG, and my belief is just looking at IgG can give you a perspective of what's going on in the immune system by, I call it more of the frequency intolerant antibody. So it's more of, what are you eating a lot of, and are you tolerating it? So that's kind of the way I have described IgG. And those, reactions can happen up to 3 days later. So I have a lot of people, obviously IgE reactions are more immediate, and then you have the IgG reactions that are late, can happen 3 days. So I have a lot of patients even that are like, I can't figure out what is happening, because they think they have a reaction. What did I just eat? Right? It can be foods that could be compiled over the last few days, and many of them. So a lot for our test, I really like it just because we do have the full look of the immune system by looking at IgE, IgG4, and obviously with the complement that we can talk about later too. So we actually do have some resources now that show that IgG is a good test for foods. So, I mean, what do you say, Jen? What about you?
Yeah, I mean, I get this a lot. When I go back and I look, who are the big allergy groups that are speaking out against this type of testing? Hands down, every time they're saying IgG doesn't tell you if you have an allergy. And
Yes.
I think part of this is just a great lack of education in the area, in this field, because IgG really doesn't tell you if you have an allergy. We just talked about this. It's
Yep.
it's IgE that's
Mm-hmm.
telling you if you have the allergy. That's why IgG on its own isn't the full story. I read a lot of stories, speaking out against these tests because people were using IgG and saying, well, I don't, like there was one that I disliked. It was hard to read through. It was a child who had a serious reaction to a dairy product, took one of these tests, or the parents gave the child a test. So the test came back showing no IgGs for milk. So the parents said, okay, great, you don't have an allergy to milk. And they gave the kid milk. The kid was in the emergency room a couple hours later, had to be resuscitated, survived, thankfully. But the person presenting this study, their conclusion was this type of allergy testing is bad. And
Yeah.
that's the problem, is that it's misinformation. I don't think
Yeah.
any of us would ever say, give your child milk based on an IgG test when you know there's a severe allergy.
Yeah.
Uh, you got to test IgG4. And even then, what we have to keep in mind is that the antibodies that you're looking at are there because you've had an exposure recently.
Mm-hmm.
So if I have an allergy to peanuts and I haven't had peanuts in a year, you're probably not going to be detecting these IgEs in me. Um, so really, this is a snapshot of where you are in your dietary journey at this very moment. What are you reacting to? Not right now, not what you will react to later or what you could react to. It's what you're reacting to right now. There's also a lot of conflicting education out there because of the skin prick tests that are done in a doctor's office. And these are the
Mm-hmm.
tests where you get these tiny pricks of allergens on your back. you're left alone for a few hours, and then you're reviewed or evaluated to see how you reacted to these different allergens that have been, uh, you've been exposed to. And you look for swelling and other types of symptoms. You're exposing a person to an antigen and looking to see how they're going to react to it. So the next question that we got was about medications. This is something that always comes up as well. How do medications affect our testing? There are two sides to this. One is, how do they affect the actual test itself when we're in the laboratory? Do they interfere with the test? And the other side of this is, are they going to affect the data that I get out of the test? Are they going to affect my immunoglobulin levels or my complement levels? I can tell you from the laboratory side, we haven't seen medications or anything that interferes with our tests as far as medication goes. We have every once in a while, we'll see that very high levels of immune activation. And I think they're probably related to people who are having severe, like seasonal allergies. That can cause a low level of activation of really the whole immune system. It shows up on our tests looking like slightly elevated levels of everything. I suspect in our case that what we're looking at is some interference between high levels of IgE with all of the other tests. We handle that on our side. If you were to ever have that happen with a patient, we can consult with you on that. And we make sure that you're counseled properly and can get another test after these weird overstimulations of the immune systems have come down. So the other side of this question, Kris, is how about medications? What about the other medications people tend to take for sensitivities and allergies?
Yeah. So we get that question quite a bit too. I always say, and what we've told practitioners in the past too, if there's a patient that's on a temporary medication or they're taking, let's say Advil or ibuprofen for a while, and if you want to wait till they're finished with those and maybe wait a day or two, then test, you feel better about that, then you can wait. We obviously don't recommend a patient to go on something that they are taking for a long time, for a year. So they can still test. And we would just say, just test them at that moment. Their body's used to that anyways. And so we can still get some results. Now, I know, Jen, you mentioned there were a few, and we kind of had researched a little bit. What was the one that you found that was causing some issues
Yes.
with the reports?
Dr. Sahani and he's another in-house MD that we have. He's our clinical guru who knows the insides and outs of the immune system. He's my mentor, and we'll have him on one of these Q&A sessions as well. He's a real treat. I learned so much when I talked to him. I had to go to him for a drug question. It was called Dupixent, and
Yeah.
it's an immune modulator drug. And so there are rare drugs out there that are immune modulators. They can knock down the ability for us to develop certain immunoglobulins. This is one of them. And so, can you stop taking this medication? And is it safe to do so? If it is, you should stop taking it before testing. If you can't stop taking it, then that's okay too, because remember, we're getting a snapshot of how your body is reacting to things right now. So if you're on an immune suppressant and you have lower levels of certain antibodies, then you're going to have lower levels of inflammation that would result from those antibodies. So you're still getting a lot of information from these tests. It just comes down to the interpretation. And again, the interpretation always needs to be done, as Dr. Sahani would say, it always needs to be done with clinical signs and symptoms. You have to look at how the patient is feeling. You have a patient with high levels of IgG and they feel fine eating a food, that's okay. You don't need to take them off that food. So that's important. Antihistamines come up quite a bit, and this is also some misinformation. I think we do a lot of AI searches these days. Antihistamines cannot be taken when you do a skin prick test. So those ones where you're having the antigens put into your body, because those are relying on histamine release to cause a reaction. They don't affect our tests. So antihistamines are not a problem. Topical medications seem to not be a problem as well. So if you have like an inhaler type medication, those don't seem to cause problems for us either. But again, if you have any questions, you can always come and ask us. At the very end of this presentation, we'll have some contact information, and you can always reach us through our website. Those questions inevitably come to me, they come to Kris, and they come to Dr. Sahani. And so we'll get answers for you. Okay, Kris, there's a new type of test out here. It's called mediator release testing. And we're seeing it a lot related to leaky gut. And it's sort of like the new allergy type testing. We had a question about the mediator release testing. And really, can you compare and contrast this test with IgG test that we have here? So I got to start just by talking about the test itself because it's a very different type of test. I really think there are only a couple companies that are really offering it right now. And this test is just very different than what we do. Blood is taken from a patient. This has your B cells and a few other of your immune cells in there. And you're basically exposing those cells to an antigen and you're looking for them to release things like cytokines and histamine. So you have a cell that's loaded with these mediators. They're like, they have a certain volume to them. They're exposed to an antigen. They release those cytokines and other mediators, and they shrink in size. That size is measured, and that is a measurement of how reactive you are to a certain antigen. And so there's value in that. Absolutely, there's value in that. The issue there with when you compare this test that we have with it, which is immune related with that test, is that test is not strictly immune related. You're looking at multiple pathways. So it's not just immune system related. And so you get some fast information, that's true. If you're looking at leaky gut, that can also be helpful, but you're not able to tease apart information related specifically to immune system like, and to your antibodies. The other thing here is that the question really was about IgG, but remember that we also have IgG4 and IgE and complement system that we are looking at. So we do have a lot more resolution on our test than just IgG. And so it's not to knock the mediator release testing by any means. It's actually very clever and impressive. It's newer, so there's less information out there about it, but it doesn't discern between purely antibody-mediated reactions versus general reactions. Kris, have you had any experience with any of this?
I know a little bit about the MRT test from a couple companies. I have not used them personally in my practice. But once I started using our testing, I found that it was really helpful. And also, the comfort for me too with our test is that we, looking at all pathways is we are also covered by insurance. And so that says, a lot about the FAST test. So that's about the only thing I can say. I don't really know enough about the MRT test. So
yeah,
I just know a little bit.
The insurance issue is a big deal. It's hard to get an insurance company to agree that a test is useful.
Yes.
As somebody who's been developing these diagnostic tests for a very long time, I can tell you it's so difficult, even just getting these things past like FDA. And so, yeah, when a healthcare company, an insurance company says, okay, we believe there's value in this test and that it's actually going to improve patient outcomes, that is paying quite a bit for us.
Definitely.
Okay, leaky gut's always a very, very big topic for us. So leaky gut came up many times in the list of questions.
Yeah.
So if leaky gut's present, we have a lot of flags for different foods. And so how reliable is our testing at that point? Is there a test in that case that can actually identify one specific food? I think it's important to actually talk about what leaky gut is here in the first place. Do you want to give an overview, Kris?
Yeah, so I explain it very simple. So it's, and you can get more technical if you want explaining it, but I explain it with between our environment, our foods, what we're exposed to, over time can create our gut to like the lining of the gut, like just those exposures, inflammation can create this, the tight junctions to separate. We want them tight. So everything else is getting leaked out into the bloodstream. So we want to tighten those junctions back up, because we don't want, our foods to be seen as a big issue, right? We want those back up, and sometimes that can happen when foods are shown as a really an issue, that we can have some of those foods brought back in, and so this is where our test comes in very well too. I get a lot of questions about, well, do you treat the gut first and then test? And we actually got this question quite a bit too. For me, I believe that you should do both. I have found with my patients that doing this test, along with healing the gut at the same time, has been really helpful. Patients start to see results quicker. They start to feel better quicker by just removing those foods. So healing the gut can take a little bit longer. So again, but everyone's so different. So that's the way it's worked for me and my patients. And I think a lot of providers I talk to have believed, or found the same thing with removing those inflammatory foods along with healing the gut has been really helpful. And again, it's all depends on the patient too. So getting them to do a diary and figuring out, I usually recommend 3 months elimination. Sometimes it's 6 weeks. We check back in, see where they're at. And then the healing the gut is usually about 3 months. I recommend to start, but everyone's so different because, just where they're at in their inflammatory, autoimmunity can take a little bit longer. Things like that. People can just depending on where they're at and how leaky they are, I should say, or inflamed. But go ahead and add to that, and then I can add some more information back in there too.
Yeah, leaky gut's a difficult one. We get this vicious cycle when we have leaky gut. So, Kris, you talked about the tight junctions. So, the enterocytes, the intestinal cells, they're really tight next to one another. Our bodies do a great job in the intestines of making sure to protect us from anything that we shouldn't have in our bodies that's going through the intestines. There's a lot of junk in there we don't want. And so zonulin is one of the factors. You guys have, I'm sure, heard of zonulin testing. Zonulin helps keep these tight junctions together. And when you have dysfunction, you've got issues where, your zonulin, you've got issues, you don't have tight junctions anymore. So when this happens, you start getting all this junk from the intestines coming into the body that shouldn't be there. Your body starts reacting. Now your body is putting out zonulin. Your zonulin is interacting with other receptors that are causing more breakdown of this tight junction. And you have this incredible, just terrible cycle going. It's very, very difficult to stop it. So you get leaky gut, you get a little bit of breaking of tight junctions, you get junk coming into the system, you're getting more inflammation, you're getting more signaling to break down even more of these tight junctions. How do you stop that? So finding what you're having a sensitivity to can definitely help. You're certainly getting a lot of stuff in there that shouldn't be in there. But finding what you can about what's in the diet that's really aggravating the situation can help lead to some healing. And I think that that's a very, very big part of healing leaky gut. I think there's a lot more to it. Supplements, I think, are very important.
Yeah.
Yeah, definitely important.
I mean, I've had some patients start removing foods right away, and within a week they call me and say, I'm already feeling so much better. So it's very helpful.
Amazing.
Yeah.
That's amazing. Yeah. So I don't think, one of the questions was when you have this type of leaky gut syndrome or disorder, well, can you pick one food that's causing the issues in your system? the testing isn't going to necessarily pick out one food. You're going to have to do a little bit of sleuthing.
Mhm.
Without that information, though, you're looking for a needle in a haystack. At least, we can narrow some things down for you, but you may find higher reactivity to certain things than to others. So there is certainly a wealth of information that's going to come out from that test and really going to make it easier for you to pinpoint or start finding foods that you should eliminate from the diet or restrict from the diet.
Yeah. Sometimes it's trial and error depending on the patient too, and just getting a really detailed um, daily food diary and having them journal, their reactions, as they have them, and then go back and look at, okay, what did I eat? So you kind of have to dial in
Yeah.
sometimes as well.
Okay, that concludes the first topic. We're going to move on to the second. So this is a sort of a cluster of questions that we got related to using the testing in clinical practice. So we've covered a good number of the things here that a good number of the topics already, but we'll cover them a little bit here, and certainly there's some new questions that came across. Um, the timing for testing has always been a topic of concern. When do I start testing? Should I be testing now? Should I be testing later? If I have leaky gut, do I test now? Do I test later? Kris, what do you think?
So if I have a patient come in and I feel like this test would be really, really useful for them, I give them options of, okay, we could start with elimination diet, right? Getting rid of the highly known inflammatory foods, gluten, dairy, things like that. Most of the time, my patients are like, no, I've tried that. And who knows how much they've done, but they really I want to dial in. I want to know exactly what foods and besides those foods, right? Gluten and dairy. So I usually start out right away and I'll give them a few things. So I'll test them. And then once I get those results, then I'll look at it and decide what the supplement plan, like you were talking about. Do they
Yeah.
need to be on a heavy dose um, of some gut healing supplements, maybe a digestive enzyme, a good probiotic, whatever it is. So and we also have some practitioners that run our test once a year. They do it with every patient in their kind of their wellness, their checkup every year, because those can change. So if you have somebody who's really, really sick and you want to really, dial in, you could test them and then retest them 3 to 6 months later, see if your plan's working, if that inflammation level's gone down, like in our total reactivity panel on our reports. I've explained to some practitioners that can be useful tool if you retest. So really, it just depends on what you're looking for too. Retesting or running it once a year on patients, as those foods can change every year.
Yeah. I think a lot of this also comes down to your comfort level
Mm-hmm.
with these tests and how to
Yep.
interpret them. When you're more comfortable with the interpretation and really dealing with some of the edge cases, some of the weird things that might come up, then you start to see more utility for these tests at all stages.
Right.
So you test before a treatment, you might want to test after because you start clearing certain types of foods that are giving you a reaction or a sensitivity, or they have a sensitivity to, and then something else pops up in the process. We did have a case with one patient who had had exposure to mold. It was a pretty severe case. This patient was doing food testing because every time the patient found a food that could be eaten without causing symptoms, the patient had maybe 2 or 3 days before symptoms started. So then the patient would switch to something else, and the patient would get 2 or 3 days until that food could not be taken anymore without causing symptoms. And so there are certain overstimulation or hyperstimulation situations. In this case, we're talking about um, a house with black molds with a constant and severe exposure. So you have a hyperactive immune system, and your body is just going to react to everything that you eat. There's a lot of stuff that you need to do to calm the immune system at that point. But as you're testing, you're going to see as you hop from food to food, certain things are going to be reacting and certain things are not. And if it becomes, in this patient's case, it was a matter of what can I eat? Because I'm hungry, what can I eat? This testing can, provide nutrition at that point. And a little bit of peace, knowing that there are a few foods that can be eaten, even if it's just for a short time, because I think you start getting into some of the psychological aspects that we see that come with autoimmune disorders and just even general food sensitivities. The anxiety that develops, the depression, and by all costs, we want to avoid having any patient sink into any of those sorts of conditions. And so the testing has utility in that sense as well. And so that brings us to the next question. If we do remove a food from the diet that is causing a problem, how long does it take until we see a change?
So I say, let's start with, I say 3 months. Let's remove these foods for 3 months and see what happens. Again, if there's a patient who is very, it's a, harder patient, they have a lot going on. Maybe they have candida show up. They have, aspergillus mold show up, and their diet plan is a little bit more intense. Then I have them check in at 6 weeks. And we kind of look at, okay, what can we add in? Maybe what are you feeling, especially when you're on, with candida and looking at lower carb, maybe lower sugar plan, what we can bring back in. And so I think that is really patient specific, but I usually say 3 months to start. I've had patients not see anything, really, really sick patients, 6 months to the day. So again, it's really patient specific, I feel like.
For those patients that it's taking longer to see the change, what do you think is happening in those cases?
Yeah, I mean, I think I pretty much have had one that I've had that I remember that took that long. She was dealing with a lot of gut issues, not being able to go to class. So I don't even know. I mean, I even had her on a lot of gut healing stuff. She journaled every single day, every food she ate and how she felt. She did start to feel better over time, but she didn't get to the point where she was 100% better until 6 months. So maybe that was just a one-off, something different. It probably doesn't happen that often. I don't see it that often, but
yeah, I imagine that you've got different degrees of severity.
Yeah.
Some people are really great at masking how bad they feel.
Yes.
And this may be
Yes.
one of those cases, especially if you've got a student who's hustling to class all the time. But I do think, for those very, very severe cases, you're fighting a long-standing, a chronic immune inflammatory response at that point. It's going to take a while for that to heal. And
Definitely.
for
And,
things
it
like
could be
leaky gut,
stress
yeah.
too.
Hmm.
Stress is a big one. Maybe, that had to do with it too. So there's just a lot of
Absolutely.
the care plan.
Absolutely. So there are other things that can happen in the body. Mast cell activation syndrome and other gut disorders have come up a lot. Let me see here. We had a few questions about this. Basically, when we have something like mast cell activation syndrome, uh, what do we do with the test results? Are the test results useful? And how do we treat a patient with those results? My experience, this has been a little bit more on the rare side. Um,
Hmm.
Mast cell activation syndrome, you have overactive mast cells. You get lots of histamine release, lots of bloating and upset stomach. Um, it's really these symptoms look just like sensitivity. I think when you're looking at this, you've got a different pathway that's causing symptoms, but I think um, you can have underlying sensitivities that are provoking some of these reactions. And best to go and find out if that is one of the underlying conditions that is making this worse for you. So I don't think that MCAS is a reason to not test. I think it's a reason, though, to be cautious with the results that you get because you can see some immune system amplification. So you can see higher levels of immunoglobulins in general. You want to make sure that you're paying attention to that when you interpret the results. It doesn't mean that the results are incorrect or that you can't make sense of them. What we tend to see, and particularly those patients who have like a severe reaction going, will have like these general increases of antibody levels. And so everything will start to flag as low reactivity, but we don't give you just, low, medium, and high reactivity. We give you actual numbers to go with them. And you'll see that like a threshold for us to get to low reactivity might be 1. And that's like 1 unit per milliliter. That's our measurement unit. And you'll see that like everything that's flagging is at like 1.05 or 1.08 or something like that. So there's just like this low level increase. And then you'll come across one antigen or allergen and it's like 13 or 5. And so you can still get a lot of information out of these tests. And so, as the lab director, I've been releasing tests when we see this phenomenon, and I do say interpret with caution, and I will counsel to say that when we see these results that um, there is some elevation there, but there's still some good data. And we'll work with any providers who have an issue like that or who have questions about these other conditions to help walk you through those results and to make sense of them so that you're able to counsel your patients and give them better service or better care. The next questions are about interpreting IgE findings when you also have sensitivities. So I guess some of the questions really are, how do you advise clients when they come back with IgE and also when they come back with IgE and IgG? If I come to you with a moderate reactivity for plums on the IgE panel, what do you do? What do you tell me?
So, okay, the way I look at the test is on page 5, there's a, where you have the severe, moderate, and then the green go. So I call it kind of like the stoplight. So if red show up, I tell my patients, and no matter what category it's in, whether it's IgE, IgG, IgG4, whatever, if it's in that red column, remove for 3 months completely. The yellows, kind of depending on the patient, their symptoms, kind of, and with how they're feeling, I'll say, maybe let's not have these all the time. But if I have somebody who's really, really sick and the list isn't crazy and we can remove both reds and the moderates, then we do that. So it kind of depends, but I think no matter where it's at, if it's in the red, it needs to be removed, whether it's an IgE or IgG. Now they may ask, well, can these IgEs maybe get worse and worse over time? Maybe. We just don't know. And I think you and I, Jen, we talked about this a little bit. Can somebody, if that shows up in IgE, maybe someday get worse and actually causing some of those immediate anaphylactic issues? And you said yes, right? So
yeah, those are challenges. Like the first challenge, you have peanuts once, you're fine. The second time, you're in anaphylactic shock. It's the number of times you're exposed can affect how serious those reactions are. So yes, seeing that your body is reacting can be a precursor to what's coming next, and that could be something serious. You have to pay attention to it. That does not mean that you're going to have anaphylactic shock the next time you eat something.
right,
You have to
right.
take these tests again along with the entirety of this patient's signs and symptoms. But it's something you need to be aware of and you need to pay attention to it. The
Yeah.
other thing that goes with IgE is the IgG4, and that you can see, and we do see, patients who have IgE and IgG4, and those patients are starting to or have developed some tolerance. And that means that they're having some reaction. So beekeepers again are a good case here. They're exposed to bee stings and the venom in those stings. So they're developing this IgE response, but they're also developing IgG4 tolerance. Then that's preventing them from going into anaphylactic shock. So there's something very important about that. Now, can you look at the test and say, oh, I have a lot of IgG4 and a little bit of IgE, so I'm fine? And I caution against that. IgG4 is telling you your body is doing something protective. That doesn't mean it's always going to be successful. It doesn't mean that you're protected from anaphylactic shock or some other state that could be very detrimental. It's telling you what your body is doing. It's that's not a green light to go ahead and consume that food. Likewise, finding these IgG4s, we didn't really cover it, but having too much of an IgG4 can actually lead to an autoimmune condition. And so that is something to also be aware of when you see these high IgG4 levels, that there may be something else to be aware of there. There may be another condition forming or that is already formed. So what do you do when you've got IgE and IgG reactivity for clum antigen or another antigen? So you're testing positive for both. So this happens quite often. This is normal. Your body is, remember, these are two separate pathways. The IgG is showing you that there's been an exposure. Whether that leads to inflammation or not will depend on the complement pathway and a variety of other things, but you're seeing that there's some reaction. It's possible to have an IgG reaction and to be totally fine. Body's not doing much with that reaction. So finding that there's a sensitivity and then finding that you also have an allergic reaction is not uncommon. Your body just has two different pathways that are reacting to that food. You probably want to pay attention to that food and prioritize removing that one or eliminating it for a while from your diet. The next one's a good one. Pediatric versus adult testing. You've got some good cases here. What do you want to share?
Yes. So, well, pediatric. So we recommend pediatric testing is okay starting at 6 months. We do have some clinics that do run our test, and they've gotten some great results with 6 months. Where, as much as they can be exposed to food, the better, as long as they can, just to see what that exposure looks like, and their tolerance to that. So I had a patient come to me, coughing, throwing up after eating. I think she was around 4, maybe 3. Parent came and said, they want to put my, child on prescription drugs for reflux or whatever it is. And so can we try this test? And so I said, sure. So we ran it. Come to find out, removing those reds, maybe even some of the yellows, I can't remember. She called me a week later and said, my daughter is not coughing or choking anymore after eating. And so fast forward, we removed those foods for a while and then slowly reintroduced one at a time. So that's how, if you don't want to rerun the test, we recommend you introduce one food at a time. I do it one a week, especially those reds, to see. And so now she doesn't do well with gluten, doesn't cause that issue, but she still has a little bit of issue with gluten, but it's come down to that. So after that much time, it's been super helpful, and obviously doing some good gut work too. So it's been very helpful I don't see any kids usually younger than that, but that was a good success story for sure.
Yeah, I like that one. Anytime we can help a child is fantastic. One of the questions that we got was about reference ranges and if those change between pediatric and adult patients, and they do not. And as you can hear from Kris's story, that we don't need to change those reference ranges. We're looking at units per milliliter. So we look at some activities here that with the way our test works. And so we don't necessarily need to change those reference ranges, and it works just fine for us. There are lots of food families that react with one another. This is common. Why does it happen? What are we looking at? What considerations should we have? Soy was one of the ones that had actually been brought up. So I can start with just the science behind this. Like a lot of foods have very similar proteins in them. they will have similar structures but be different foods. And so in that case, your body reacts to one protein in a food, but it can't tell that that protein from the other food is different. It looks very similar. And when that happens, you start reacting to a different food. And so the big one here is tropomyosin. This is associated with muscle movement. And there's a version of it in vertebrates, and there's a version in invertebrates. So shellfish is the big one. And it happens to also be in desmites. The version in vertebrates doesn't seem to cause the same problems, but a person who has an allergy with shellfish is more likely to have an allergy for desmites because tropomyosin is pretty much conserved between these different species. And so that's pretty common. And so you can look online. There are a lot of different families that are up there. The proteins for a lot of them that are cross-reactive are identified. People are pretty well aware of them. They're classified. There's like a nightshade group is one. There's even a latex fruit syndrome. So people who have allergies to latex may have allergies to specific fruits. I can list them here. I've got the short list here: bananas, kiwis, avocado, chestnuts. And it's because there's a protein in those that actually mimics natural latex. And so that's what we're talking about when we say cross-reactive. So,
Mm-hmm.
Kris, if somebody is allergic to something like soy, do they need to remove things that are similar to soy or that might be cross-reactive to soy?
Again, it's always trial and error, I say. I always tell my clients, let's start small. We can always go deeper if we need to. So I guess it depends on the patient and if they want to go that far into it in the beginning, right? So I'll start out and say, let's start with this. How does that feel? And usually people at first, when they get this test result, they're like, whoa, let's start here. I usually don't send the report prior to reviewing it because I've had some people in a panic. So I usually start small. We can always look at the bigger picture, or dial in deeper, I should say. I mean, I've had people say, I never eat this food. Why did it show up? And to your point, like cherry has shown up before. Well, that's cross reacts with some of the environment. I think it's birch or something, so there's some environmental reactions that can, cross react with some of these foods as well. So depending on how far we need to dial in, I kind of I would start with soy and then see.
Yeah, the specific question we had was about soy. I looked up the cross-reactivities for soy. They include peanut, green pea, chickpea, kidney bean, navy bean, lentils, and list goes on. There are
Yeah.
also some fruits that show up, vegetables, seeds.
Yeah.
So no, don't wipe all of those out. If you know
No.
you have an allergy or a reaction sensitivity to soy, see how you do when the soy is taken out. If you have cross reactivity, it's going to start to show up, but you might also see some of that cross reactivity on the test. Just because you see the cross reactivity doesn't mean that you're going to feel the cross reactivity. Sometimes the ability for these antibodies to recognize uh, another antigen or an antigen in a different food doesn't mean that the same reaction is going to come from that antibody. Sometimes those reactions or the recognition to a slightly different protein isn't strong enough to actually cause inflammation or another reaction. So I wouldn't jump the gun, but I would eliminate the food that you know you're having a problem to, and then see how you do from there. But if you're allergic to soy and you start to see chickpea and navy bean and these other things show up, you may have cross reactivity to just be aware of. So when you take soybean out, you may need to consider pulling another couple foods out with it.
Yeah. And then
Um,
another time to have a food diary be super helpful as
yep,
well.
absolutely. I think we're just about out of time here. Are there any last things that you want to say before we get to the last slide with some contacts?
I think I'm going to make one more point because we get this question all the time with providers asking, or patients even asking, okay, I never eat this food. Why did it show up? And this kind of goes back to the cross reactivity with the environment. So just take that into consideration that they were exposed to it somewhere. If it's showing up on the test, they were exposed. And you also have to, from experience with patients, really dial into them and, well, did you eat out? Do you know exactly, like, do you know what they used in the pan before? Are you for sure that they didn't use soy oil or, some type of soy in the pan and didn't clean it well enough? I mean, the exposure has to be minimal. So I get that question a lot. So I just wanted to point that out before we finish up because
Yeah,
I get that quite a bit.
it's so hard to control, especially if you're going to go eat out. I
Yes.
wish we had more time to talk. We will definitely be holding more of these sessions. If we didn't get to your question and you still have questions, or you've had new questions come because of this seminar, or because you want to work with us and you haven't yet, or you want to reinitiate working with us, or any other reason, please, please, please reach out to us. We love hearing from you guys. Like, we really do.
Yeah.
Our general email address is clientservices@infiniteallergylabs, but you can reach Kris directly and you can reach me directly. She's K Ball, I'm J Knaack, and we're both at infiniteallergylabs.com. You can also get to us by calling on the phone. I think Kris and I tend to work better by email. So please shoot us an email. You can even email both of us and we'll both respond. We're on the hook for this. If you want to find us online, we've got our website down here. You can also find us on Instagram and LinkedIn. We got a lot of cool stuff posted on LinkedIn too to keep an eye on. So thank you guys so much for joining us. And Aoife, thank you for moderating. Kris, thank you so much for everything
Yeah, it's
you've done for
great.
us and all of your clinical insights. And you have the best stories. Thank you guys. We'll hope to
Okay.
see you at the next session.
Bye.
Bye.